I'm Christian Vrints. Acute coronary syndromes are an important topic in acute cardiovascular diseases. We will discuss together with João and Jurriën Berg, the management of acute coronary syndromes, especially focus on the timing of revascularization and on the antithrombotic treatment. This morning we discussed a very interesting case of an elderly patient who entered quite early into the hospital, who was on treatment with oral anticoagulants. And my first question is, when should we send this patient to the cath lab? Should we stabilize first the patient, or should we go immediately to the cath lab?
Well, I guess it's maybe more difficult to answer the timing in patients who are on oral anticoagulants, but in general it depends on the risk, the thrombotic risk of this patient, and probably it's the same as the patient who is not on an oral anticoagulant. So in high-risk patients it is within 24 hours.
And suppose the patient is low risk, would you then stop the oral anticoagulation or bridge it? For instance, if the patient is on a NOAC, would you stop the NOAC or?
Well, it's quite a controversial issue. The guidelines have stated already that if the patient is on VKA, you should continue the VKA in the cath lab. And if the INR is above 2.5, you can even do a PCI without heparin. And usually when the patient is on NOAC, they stated that we should discontinue the medication before going to the cath lab and then take over with heparin only in the cath lab during PCI. But the new guidelines were just presented a couple of hours ago, and now it has changed. So also if the patient is on a NOAC, you should continue the NOAC in the cath lab and perform PCI only with low dose heparin on top of the NOAC.
And João, suppose the patient is a high risk patient, should we consider pre-treatment with antiplatelet agents or?
The issue of antiplatelet treatments, the pre-treatments before the cath lab in patients non-STEMI is changing. It's a controversial issue. We are using pre-treatment for more than 10 years ago. Within the last 3 years, this issue was repriced. Regarding the data on meta-analysis, showing that there is an increase of risk of bleeding in these patients pre-treated with a small benefits, and is based also in the results of a COAST trial in patients with prasugrel, showing that there is any benefit on pre-treatment and there is a clear increase on the risk of bleeding. So today it is clear, and guidelines are saying that you should not use prasugrel in the pre-treatment, and the guidelines are omitting recommendations regarding clopidogrel or ticagrelor regarding the lack of evidence with these new drugs.
And maybe in addition, for patients on oral anticoagulants, the new guidelines, as I said, just presented, are against pre-treatment. So no P2Y12 inhibitors, so also not clopidogrel, which is a less strong anticoagulant, in these patients who are on oral anticoagulation already.
So the question is, if you proceed to the cath lab in the next 24 hours, avoid any form
avoid the
of
P2Y12 inhibitor. Yeah, so that's new.
So in summary, in a patient with an acute coronary syndrome, we have to go to the cath lab depending on the urgency and the severity of the ischemia. If the patient is on a NOAC, we have to continue the NOAC at the lowest dose, and we have to give triple antithrombotic therapy for at least 1 month. Thank you.